he did a wonderful one, kind of some of the basics about sleep in the fall, and now I'm going to do a deeper dive into sleep disorders revenge. And Nathan Walker is a longtime physician dealing with sleep. So take it away. And please, folks, if you have questions as we go along, you can either send them to me in a chat or just call them out. So
Yeah,
yeah.
stop me anytime. I'm happy to answer questions. I'll open the little chat box so I can see if you send them there. So like Liska said, I'm going to talk more about, I mentioned some sleep disorders in the last talk, but here I'm going to kind of go into a little deeper dive about the 3 of the most common sleep disorders. Let's see if there we go. So I'm going to talk about obstructive sleep apnea, insomnia, and restless leg syndrome. They are 3 of the most common sleep disorders that probably somebody in this group has. So first I'll talk about OSA, obstructive sleep apnea. So what is obstructive sleep apnea? Well, it's defined as one or more of the following. So you either have to have snoring, or somebody says it looks like you stop breathing or have long pauses in your breathing in your sleep. You have sleepiness, you're excessively sleepy during the day, or you feel fatigued. Sometimes people explain it differently. You have insomnia. You have trouble falling asleep. You wake up frequently. When you do wake up to start your day, you don't feel good. You don't feel refreshed. You have non-restorative sleep. Or you wake up with episodes of choking or gasping. So you have that apnea episode and you kind of wake up after it, your airways pops back open and you feel like you've been choking or gasping for breath. And then you have to have it proven on a sleep study with an AHI, apnea-hypopnea index, I'll talk about that in a minute, of 5 or greater. Everybody's allowed to have a few, but if you have 5 or more, we say you have sleep apnea. Or you can have absolutely no daytime symptoms. And you just have an apnea-hypopnea index of 15 or more, which is moderate and above. So what are an apnea and a hypopnea? An apnea is a pause in breathing, an actual stop in your breathing. It's a cessation of airflow lasting for at least 10 seconds. So on a sleep study, this looks like, boom, you're not breathing. We have on the airflow channels, we look at are you moving any air? But you still have effort. You're still trying to breathe. And then it's usually accompanied by an oxygen desaturation. So your oxygen levels dip while this is happening because you're not breathing, and usually accompanied by arousals. Your brain and body don't like this, so you wake up, your airway opens back up, and then you go back to sleep. Then you can have hypopneas, which is basically too shallow breathing. So it's not a complete apnea. There's not a cessation of flow, but there's a reduction in that airflow. Again, lasts 10 seconds. And then that you care, but also defined by at least an oxygen desaturation of 3%. So your oxygen has to dip at least 3%, or you wake up. So you have this hypopnea, you have this reduction of flow, and then you wake up afterwards. So apneas and hypopneas usually last 10 to 30 seconds. They have to last 10 seconds. It can't be any shorter. We don't count it, but they can last up to a minute. And sometimes I've seen slightly longer. So they can be pretty long. When is apnea or hypopnea worse? Usually in REM sleep. In REM sleep or dream sleep, we're paralyzed. Our bodies don't move except for our diaphragm and our eye muscles. So what's happening in obstructive sleep apnea is that the upper airway, which is just supported by smooth muscles, is collapsing or getting too narrow. Those muscles are completely paralyzed in REM sleep. And then it's also worse in supine sleep. Most of our airways collapse. When they do collapse, front to back. So when we're laying on our backs, you're more likely to have the airway narrow or collapse. So we define it by AHI, or apnea-hypopnea index. So again, apnea, pause in breathing, hypopnea, too shallow breathing. And the AHI is the number of these events per hour of sleep. So when you have a sleep study, how many do you have? And so the severity is based on that index. So, and you're allowed to have a few. Less than 5 is considered normal, but if you have 5 to 14, that is considered mild sleep apnea. 15 to 29 is considered moderate, and anything 30 and above is considered severe sleep apnea. What's the prevalence? Well, roughly 2 to 26% of the population have it. This changes depending on what population you're looking at. In the general population, this is estimate. It's a little bit higher for men aged 30 to 70, 13 to 14%, roughly 5 to 6% of all women. But this increases in prevalence with age, which levels out around 65. So as you get older, the likelihood that you have sleep apnea goes up and up and up till about 65, and then over 65, it doesn't seem to make it more likely. But depending on where you look, anywhere between 50 to 80% in different studies. So in a US-based study, it was people over 65, 50% of people over 65 are is thought to be the prevalence of sleep apnea. In a European study, it was even higher, about 80%. Women are protected up until menopause, and then they start catching up with men in terms of the incidence, the prevalence. So what happens to your body? Why is this bad for you if your airway collapses and you can't breathe very well? Well, it increases the fight or flight response, so the sympathetic nervous system. So the increase in heart rate, increase in the release of stress hormones, increase in blood pressure. You know, the I have to do something. This is and it happens first just at night, just when you're having the events, but eventually over time, this becomes a 24/7 response, and it's ramped up all day, every day. It also increases damaging free radicals. So this damages your blood vessels. It hurts your heart, hurts a lot of organs. It increases inflammation. So having obstructive sleep apnea, you have more inflammatory response elevated, which your body doesn't like all the time. It increases the workload on your heart. Your heart has to work harder if you have obstructive sleep apnea, both pumping the blood out to the body and pumping it to the lungs. And it causes fragmented sleep. And there's a lot of health effects from just if you didn't have sleep apnea, but you don't have good sleep, you have similar health problems as well. So what are some symptoms you may have that make you think, well, I might have sleep apnea? Excessive daytime sleepiness is one. I am excessively sleepy today. If I sit still, what's my likelihood of falling asleep? There's something called the Epworth Sleepiness Scale. It's an 8-question little scale that ranks your likelihood of dozing or falling asleep in certain situations from 0, you wouldn't, to 3, there's a high likelihood. So you score 0 to 1, 2, or 3. And it's questions like, if you were to lay down in the afternoon, most people probably would fall asleep if they were to lay down in the afternoon, but would you fall asleep? You know, what's likelihood if you're reading, if you're watching TV, if you're talking to somebody? You'd be surprised that people with sleep apnea can just be so sleepy that if it's not their turn to talk, they may fall asleep. So excessive daytime sleepiness is a big symptom, but a common complaint, but not universal. You can have sleep apnea and not be sleepy, and it also doesn't correspond to the severity of this the sleep apnea. So somebody with severe sleep apnea could feel wide awake, and somebody with just very mild sleep apnea may not be able to stay awake at all. They might be falling asleep in their saddle. So what else can happen? Cognitive dysfunction. This is common as well, and this is a lot. The sleepiness plus the cognitive dysfunction results in a lot of motor vehicle accidents. You have decreased vigilance. You are not as quick. You don't pay attention. You might miss things. You have impaired concentration, or you're easily distractible. It's hard to focus on things. multitasking may become more difficult for you. Slow processing, it's going to take you longer to do things. Okay, well, if I used to be able to be faster with this, now it's taking me tasks that I used to be able to do in 20 minutes, now it's taking me 40. And memory difference, you might go, well, I feel like I'm almost getting Alzheimer's. I'm having trouble remembering things. People are telling me we've had these conversations, and then I don't remember them. You're more likely to have a mood disorder. So there's a higher rate of depression and patients with OSA. And then there's the sleep-related symptoms. So snoring, of course, dry mouth. So you may wake up in the morning, dry mouth. We breathe through our noses. We're supposed to breathe through our noses. Our mouths are for eating and for talking. But if you can't breathe through your nose, what do? You open your mouth. So when you're having sleep apnea, the natural kind of reflex is to open your mouth. Your mouth is open all night. You often get a dry mouth. You can wake up with morning headaches. Your brain and the blood vessels don't like this kind of dipping of the oxygen every time you have an event, and that can result in headaches when you wake up. And then when you get up and start moving around, you're awake. It's sleep apnea, not awake apnea. So it goes away, and then the headache goes away. So oftentimes if you go, every morning I'm waking up with a headache, maybe sleep apnea. Restless sleep. Like I said, these events are often accompanied by arousals that you wake up. Now, everybody wakes up at night, whether they know it or not. Anytime you change positions, you've woken up, whether you remember it or not, and you have to be awake for a few minutes to actually start making memories. But if you're having these arousals, you may find that waking up a lot during the night, and having sleep apnea can make it harder to get into the deeper sleep. If you're having it severe enough, it may just be causing so many arousals that you can't get from the lighter stages of sleep into deep sleep, and then you're more likely to wake up for all kinds of different reasons, not just the sleep apnea. And finally, nocturia, frequent urination at night. Now, as we get older, especially men with large prostates, we might get up more to go to the bathroom, but you'd be surprised how often somebody comes in and they have the other symptoms, snoring, feeling sleepy during the day, etc. But also, well, I get up to pee 4 times. And they're over 65, and I think it's my prostate. But then you treat their sleep apnea, and they go, I don't wake up anymore to go to the bathroom, and it's all related to the sleep apnea. Then having sleep apnea, obstructive sleep apnea, is associated with a lot of other medical disorders. So high likelihood of association with hypertension, with high blood pressure. So somewhere between 20 to 50% of all patients with high blood pressure have, I would say this is even higher in drug-resistant hypertension. So it is actually the recommendation that if you are on 3 antihypertensive medications, blood pressure medications, that you get screened for sleep apnea, because there's such a high association. It may even be a little bit higher than 83%, but it's so high that you go, okay, well, we need 3 drugs to get your blood pressure to where it needs to be. You're very likely you have sleep apnea, but you're more likely to have a heart attack, myocardial infarction, a stroke, depression, congestive heart failure, asthma, COPD, atrial fibrillation, type 2 diabetes. There's a 5-fold increase in traffic and industrial accidents. So this is why pilots, bus drivers, etc., all have to be screened, and then if they have sleep apnea, they have to be treated to actually continue to do their jobs. And the mortality is increased, especially if it's left untreated. If you more so for the moderate to severe sleep apnea, but if you have moderate to severe sleep apnea and it's left untreated, 40 to 50% of those patients are deceased in 15 years. So it'll really shorten, can really shorten your life. So what do you do about it? What are the treatments? Weight loss is a big one. The obesity makes you more likely to have sleep apnea. You can treat nasal congestion, and that can help a little bit, but really these These three are the big ones. So PAP therapy, which stands for positive airway pressure, CPAP, BiPAP, most of it. There are dental devices, so an oral appliance, so a mandibular advancement device, and I'll talk about these more. That's what that one is, or tongue device. This is rarely used. And then there's surgeries. The big one, the newest thing is the Inspire device. It's a hypoglossal nerve stimulator. I'll talk about that. And then more drastic thing like surgeries where they basically break your jaw and make it longer and try to open up that airway. Yeah, they're pretty they're pretty drastic, and they're not really great because oftentimes they don't work. So what's the best treatment? The first line treatment is PAP. Stands for positive airway pressure. And so usually most of the time it's CPAP. The C stands for continuous positive airway pressure. So it's just one pressure, whether you're breathing in or breathing out. CPAP or PAP is the most effective treatment. What makes it less effective is adherence. It's not everybody's favorite. It takes some getting used to. You go to sleep, you don't put things on your face and on your head and so on. But now you have to if you have sleep apnea. So it's limited by adherence. There's a large compliance is an issue because it's just hard to get used to. And what does it do? Well, it delivers pressure to the upper airway. So that airway is narrowing or collapsing at night. So it just blows air and keeps that airway open. Very simple. You put a mask on your face. There's about 150 different masks out there, but they're all kind of variations of the theme. The FFM is a full face mask. So there's full face masks. There's kind of hybrid full face masks. So the typical full face mask, probably what you think of, it's the one that fits over your nose and your mouth, and blows air in both your nose and your mouth. The hybrid is, again, fits over your mouth, but tucks up tightly against your nose. And there's nasal masks, where it just fits over your nose, or nasal pillows, which is like a little mustache that goes under your nose. And people go, well, which is the right mask? For me, if I have sleep apnea, well, the one you wear, that's the right mask. There might be one that maybe treats your apnea a little bit better than others, but it doesn't matter if you're not going to wear it. So the mask that you're wearing, that's the right mask. So just examples, this is a nasal mask, so fitting over the nose. This is a nasal pillow mask, just fits underneath. And these are full face masks. I've never, ever, ever seen a patient use this giant, I think the one that truly covers your full face. I've never heard of anybody using this one, but it exists. Most of the time it's this, which is the regular full face mask, or this one. This was the hybrid. So it's blowing both in the tight seal up against the nose, but it blows in your mouth and your nose. Now, if you can't tolerate CPAP, and I always recommend you start with CPAP, we'll do our best to help you make it comfortable, whatever happens. You try CPAP, because if you tolerate it, it is the most effective, almost 99% effective if you can tolerate wearing it. It reduces efficacy. If you look it up, efficacy is going to be reported as lower because of compliance. People don't use it. So what other things you can do? Well, an oral appliance, or what really is typo there, mandibular advancement device. So as you can see, it looks like a retainer. These are just two examples, but you fit it in over the top and bottom teeth, and it pushes the jaw forward. And so it's trying to pull those tissues along with it to keep the upper airway open. It is best for mild to moderate sleep apnea. Severe, it's not going to do enough if it does anything at all. Overall, it's only 50% effective in reducing your apnea-hypopnea index to less than 5. So basically normalizing it, getting rid of your apnea completely. And who does this? Well, you go see a sleep physician such as myself. And then if this is something that you're a candidate for and want to do, I refer you to a dentist that's trained in sleep. So what they do is they take a look and say, okay, well, one, you have to have enough teeth for them to fit on. And then They see, if there's any other contraindications for having one, but basically, how far can you push your lower jaw forward? The maximum amount this will go then is 80% of that. So it's adjusted based on the patient. So then it's made specifically for that patient. They make a mold, send it to a company. The company, makes the device and sends it back, and then you get used to wearing it. So you pop it in at night, and it pushes that jaw forward, and see if it works. It is usually fairly well tolerated, probably more so than the CPAP, but it's not as effective. And then there's a bunch of different surgeries, but the newest surgery is a hypoglossal nerve stimulator. So the hypoglossal nerve is the nerve that innervates the muscles of the tongue. And so there's a little device that is implanted in the little pocket under the skin in the chest, with a wire that goes down onto the muscles between the ribs, intercostal muscles, to detect when you're taking a breath. And then there's another little lead that goes up through your neck onto the hypoglossal nerve. So it detects inspiration. When do you breathe in? Stimulates the hypoglossal nerve on one side, and your tongue involuntarily moves forward. Again, this is kind of the idea is that it's pushing the tissues forward, stimulating those muscles so to keep the airway open so you don't obstruct. Only 1 in 4 patients that get this get complete resolution of OSA, so that means an AHI less than 5. This is enough by itself to eliminate your sleep apnea. But effectiveness in the trials to get this approved was resolution, that it completely fixed your sleep apnea and your AHI was less than 5. Or there was a 50% reduction in the severity of your sleep apnea. So you had an AHI of 60 and you got this device, and then afterwards you have an apnea-hypopnea index of 30. That was success. Granted, you went from severe sleep apnea to severe sleep apnea, but that was considered success. Or patient satisfaction. You were happy with this, whether it worked or not. You were just happy with it. That's effective according to the company that makes it. So it's a smaller device that's implanted in the chest, and then there's a little lead that goes down, and then the lead goes up. You get this little remote control to turn it on. You may have seen commercials where somebody goes boop and turns it on. So you just do this, and it turns it on, and then you go to sleep, and it starts moving your tongue. Any questions on sleep apnea or treatments before I move on to insomnia?
I have a quick one, Dr. Walker.
Sure.
I have a quick one for you. Would that be for somebody, the stimulator, would that be for somebody that the PAP just does not work for? Or would that be like second line?
Yeah,
Treatment?
to me, it's second/third line.
Oh, okay.
So yeah, it's
Okay.
not something that jump right for. Even indication, even the company itself says you should try CPAP first, and it's for CPAP failures. So
Gotcha.
all of the, for anybody across the board, no matter no matter really the severity of their sleep apnea. If you have sleep apnea, I say CPAP first, just because it is the most effective if you can tolerate it. So you do, you give it the old college try, you do your best. There's lots of tips and tricks if you're, depending on the problems you're having with CPAP, try to make it, more comfortable. But if it does not work, okay, I just will not wear this thing, or the patient just flat out refuses to even, try, then I move on. And I usually move on to the oral appliance because it's not invasive.
Non-invasive. Okay.
So you get that, and it may work, especially if you have mild to moderate. It may be enough. You can get lucky. You may get lucky with it being effective enough, especially if it's mild to moderate. This might be all they need. And I've had patients that totally worked for them, and then I don't even see them anymore because they check in with the dentist. To
Gotcha.
See if how they, the appliance is holding up. They wear out after a while, but they check in there. But as long as they're wearing it, and we retest everybody once they get the appliance and they are adjustable. So, they may say, well, let's start with your jaw pushed out only so far, and then you can adjust it and push it out to,
you can move them.
yeah, the maximum being 80% of how far you can do this. Naturally. So you can move them a little bit. So they come in and we might make adjustments, and if it works for them, great. And then I don't see them ever again. But I always start with that. And then if that doesn't work, okay, we can try the Inspire device.
Okay.
That's an option. I mean, you
Interesting.
feel it. It's an involuntary movement of your tongue every time you take a breath in. So, depending on the severity, it may not work, and it's not for people with mild sleep apnea.
Gotcha.
And it's invasive. And once it goes in, another point is once it goes in, it doesn't completely come out. The little, battery and stimulator and that come out, and the lead that goes down to on the muscle between the ribs comes out, but they just cut the lead of the neck because that lead goes on to the hypoglossal nerve and kind of scars down on it. So they basically just cut it and go, yeah, it's not coming out without real risk of damage to the nerves. So
interesting.
It's kind of a last resort.
I see. Thank you. That's very helpful. Very interesting.
Yeah, and Angie Thompson, who doesn't have the ability to tell us herself because of speaker issues, but she texted that I have CPAP and a myo brace to help with TMJ issues. I have mild OSA. I tape my mouth shut to keep it shut, and I also have clear aligners to take care of the TMJ jaw issue.
Yeah, so that would be another reason. That would be you may probably not a candidate if your TMJ is bad enough. You're not a candidate for the oral appliance because it'll just make the TMJ worse. All right, so I'll move on and talk about insomnia. Extremely common as well. So insomnia is difficulty in falling asleep or staying asleep, or both of those. Lasting, at least 3 nights a week, because we all experience this at least, a night of insomnia at least in our life. But it's only considered a problem if it's happens 3 nights, on average 3 nights a week, and then causes impairment in daytime functioning or just causes you distress. You might go, I function pretty well, but it bothers me. I do not like, the struggle with sleep every night. It is the most common sleep disorder that most everybody's had, and it increases, as you can see in this chart, it increases in incidence with age, and is except for in the 30s, for some reason that we're not quite clear about, but except for in the 30s is more common in women than it is in men. So again, like I said, difficulty in initiating sleep or maintaining sleep occurring at least 3 nights. If it's less than 3 months, it's acute. If it's greater than 3 months, we call it chronic. And causes usually multifactorial. Usually there's a lot of things that are playing a role in people's insomnia. Medications, such other substances, there's a lot of medications that are prescribed that interfere with sleep. There's a lot of things out there that we take over the counter, and supplements that interfere with sleep. The most common used, over the counter drug or substance is caffeine. Guess what? It interferes with sleep. So there's so many people that drink coffee or do other have other things, sources of caffeine. And then there's a entity called psychophysiologic insomnia. And that is inherent to you, the person with insomnia, that There's something about your wiring, something about you, that makes you more awake. So in those kind of the exact opposite of excessively daytime sleep, they are too awake. They may get only 5 hours of sleep or less a night, but what's the likelihood you could fall asleep, if you laid down to try to take a nap? Oftentimes they'll say there's zero chance. There's zero chance I'll be able to fall asleep. If you don't have insomnia and you got less than sleep than you need, all of us, if we don't have insomnia, would fall asleep if we given the opportunity. But they will not. They're just so there's some inherent thing, and it's probably one thought is that evolutionary speaking, it was advantageous because these people that woke up and when the predator came in the cave, you woke up. And your vigilance system was just a little bit more ramped up than others. But it's a problem. It becomes a problem now when it's kind of out of control. And then a lot of mood disorders and a lot of health problems disrupts them and can cause insomnia. So what are the health effects of having insomnia? Well, there's an increased risk in cardiovascular disease. This is very similar to the health risks of OSA. There's an increased incidence in type 2 diabetes. There's increased mortality, and this is more so for men and more so for the sleep duration. So if you say, okay, I have insomnia and I have difficulty falling asleep or staying asleep, and I only get 5 hours of sleep versus 4 hours versus 3 hours, the shorter the duration, the increased mortality. And it's also associated with a higher risk of developing dementia. It's not cause and effect, but people with insomnia are more likely to develop dementia as they age. So what are the treatments? The best treatment is cognitive behavioral therapy for insomnia. It is the first line treatment. Targets a lot of different aspects, psychological, behavioral, cognitive, how you think about going to bed. Lots of times when insomnia, there's often a trigger. Sometimes people don't know, and then you can't really place a trigger, but sometimes I had this bad car accident, a loved one died, something traumatic. And after that, it started. And then you start going, you get you start thinking about bed in a different way. You go, here it comes. It's a self-fulfilling prophecy. I'm going to struggle tonight. And you are going to struggle because you tell yourself you're going to struggle. So it targets different things, and I'll go more into it. And is a recommended treatment, has the most long-term success. Then there's medications, which are hypnotics. The benzodiazepines or benzodiazepine like substances like Amidia and Lunesta that don't work long term. They're better for really acute things. So less than 3 months insomnia. And the use of these medications long term are associated with the development of dementia. You're more likely to develop dementia if you take these medications. So they're what we call the Z drugs. Ensopiclone, which is Lunesta, Zaloplam with a Sonata, and Zolpidem or Ambien. They act on the same receptor that alcohol does, and the benzodiazepines, and therefore can have similar unwanted side effects. And then the kind of newest class of medications are the orexin antagonists. Orexin is what narcolepsy patients are missing. And so it can give you narcolepsy-like symptoms. So there's suvorexant, which is Belsomra, daridorexant, which is something called Quviviq, and lemborexant called Dayvigo. They block orexin activity. And orexin is a neurotransmitter located in the hypothalamus that it just basically goes to every part of the brain, and it's involved in wakefulness. And so it blocks that, and people get sleepy. But there's no evidence out there that any of these work past 6 months for the Z drugs. Basically, the efficacy is gone. These patients don't do any better than patients that are on these drugs 6 months out. And for the orexin antagonists, a year out. So they last a little bit longer, they're a little bit more effective, but then after a year, those people aren't any different than patients that aren't on those medications. So what does work in the long term? And if you have, especially if you have psychophysiologic insomnia, it's something that's going to be lasting, more than a year. I have, in my career, I have only seen one acute insomnia patient, because by the time they get to me, they've had it for months, but most of the time, years, if not a decade or more. So what's going to work? Cognitive behavioral therapy for insomnia. It's a special cognitive behavioral therapy. There's multiple different ones, but there's one tailored for insomnia. It is the guideline recommended first line treatment for chronic insomnia. And it does, like I said, it does have evidence that it works past a year. It's usually guided by a therapist or a physician such as myself, but it can also be done at home. They've developed apps for your phone. There's one called CBTI Coach that was developed for the VA in conjunction with Stanford. It is the one I recommend because it's free and it's good. But the other ones can be much more, like can be expensive. You gotta get up, pay for monthly services. And so what does CBTI involve? One of the kind of cornerstones of it is something called sleep restriction, though I don't like that term because then why do people see me? I'm not getting enough sleep at night. So I go, well, I'm going to restrict your sleep. That's not what they want to hear. I like to call it a sleep window. So it's basically just a method to restrict time in bed, not actually restrict sleep. The sleep window is a much better term. So basically you say, okay, I get into bed at 10, but it takes me 2 hours to fall asleep. So you're not really falling asleep till midnight. And then, once I am finally asleep, I sleep till, 6. And that's when I wake up. So I'm only getting 6 hours of sleep, or I'm only getting, less than 5 hours sleep. So what you do is you go, okay, well, don't get into bed at 10. Don't get into bed at midnight. And don't, and make sure you don't get into bed any early. And then get out of bed at 6 and don't get out of bed any later. So you stay within that window. So you say, well, you're shortening my time in bed from 8 hours to 6 hours, but they're not sleeping for 8 hours. They're only sleeping for 6 hours. So you get it to where they go, okay, I'm falling asleep faster because I'm going to bed later. And when that starts to kick in, and this does work, then you can start to ease that window back by small increments, and say, okay, well, now we got to get you your 8 hours. But since you're only getting 6, we'll fix the insomnia and then adjust it. And then these other parts, stimulus control, which is another big part. So you do not want to be stimulated when it's time for bed. This is why I say, especially with kids and disengaged from screens, and that's advice for everybody. At least an hour before bed. If you watch the news before bed and it riles you up, I do not like what I see on the news. Guess what? Stop watching the news before you go to bed. Things that are going to get you not in a good position to be able to fall asleep. Don't watch TV in bed. Don't read from bed. So one of the things is to not be stimulated when you go to bed. You can do 2 things from bed. You can sleep or have sex, but don't do anything else. Then relaxation, this, one of the things is progressive muscle relaxation. You kind of focus on your feet and, or you can go head down, but it's usually for the feet up, and you focus you really concentrate on relaxing your muscles. Start with your feet, then move to your legs, then move to your body, then move to your arms and your neck. Meditation can help, as long as it's not a very stimulating meditation. Some people's meditations that they do can be very stimulating. You want a very calm, relaxation. And then, the cognitive therapy, and oftentimes this is I do some of this. Lots of times therapists will do this. How do you feel about bed? So we got to reframe that bed is that time where it's a struggle, it's a fight. Here comes the fight. That no, this is going to be okay, or this is the time when I think about things. One of the things that is helpful is, well, some people with insomnia ruminate, as we say, whoa, I have trouble falling asleep because I lay down and I think about all the things that happened that day, all the things I got to do the next day, I think about certain things. So one of the things to do is write those things down. So you basically keep a journal. But if you're somebody that lays down and just sits there and has trouble falling asleep because you're rehashing that day, or you're thinking about things you got to do the next day, before you go to bed, you write them down. You've thought about them. The act of writing it down helps get it out of your mind. Then you go, I've done this. I don't have to think about this. This now. So there's lots of different things. Sleep hygiene is helpful by itself. It won't do anything for your insomnia, but it is helpful in helping us. You want, make sure you exercise during the day. You're more likely to fall asleep, be able to sleep better at night. The room needs to be cool. It needs to be dark. It needs to be quiet. Do not sleep with, the TV on. Some people go, well, I need the noise. If you need some kind of noise, you need constant noise. So white noise machines, a fan, something where it's constant and your brain will eventually ignore it. You can't ignore TV. It's flashing. The commercials are 100 times louder than the actual show that's on. There's lots of things that are just going to disrupt your sleep. So don't sleep with the TV on. So all these things work together to help with insomnia. And it's the only thing shown that works longer than a year. Questions on insomnia? Okay, I'll move on to the final disorder I'm talking about, restless legs, because it's another kind. So restless leg syndrome is also called Willis-Ekbom, but nobody actually uses that anymore. They're the two people that described it first. And it's often associated with something called periodic limb movements of sleep. So periodic limb movements of sleep are kind of the motor sign. So restless legs is not a motor problem, it's a sensory problem. The movement is kind of a secondary thing. So what happens is people move their legs at night, mostly flexion. So flexion at the ankle, so you kind of flex the foot up, or flex at the knee, flex the hip, or all three together. And as the name applies, it's periodic, occurs every 20 to 40 seconds. If you have this, there's a high likelihood that you have restless legs, but you can have periodic limb movements of sleep and not have restless legs. It's also seen in people with obstructive sleep apnea. But if you have restless legs, you will have periodic limb movements of sleep. So people, so obviously bed partners would go, well, yeah, their legs are moving their legs all day, or all evening, and then when they get in bed, they're kicking me in their sleep. So restless legs is a sensation. It is an uncomfortable sensation of the legs, an urge to move the legs. But it can also be any limb, but it's an urge to move. That's the big thing. It's an urge to move them. If I keep them still, it's going to drive me insane. I cannot. It is torture to keep them still. So oftentimes people with restless legs experience this when they're in a car. There's not much room to move your legs, or they're on a plane, really tight, not much room to move your legs, and then it gets really bad and I have to move my legs. And it can be accompanied by other sensations. Sometimes there's a creepy crawly sensation. It feels like something's crawling on my skin. Some people describe it as pain. Other people describe pins and needles sensation. Lots of different ways to describe it, but the underlying thing is an urge with that, whatever sensation, the urge to move. And it occurs mostly at night. Like I said, you can happen during the day, especially, I'm in a car for a long car ride, I'm on a plane, but mostly it's at night, in the evening, or when you're really sleepy, or when you first get into bed. So it occurs at rest, because moving the legs or standing up often improves or completely relieves the sensation of sitting down. Oh my God, it drives me crazy, and then when I stand up, it goes away or it gets better. It can occur rarely, well, every once in a while I get that sensation, I'll experience that too every day, every night. And the patients I see, they're having it every night, and it's really severe. And so this could be mild. Okay, I get it, but I can ignore it. Wiggle, I stand up, walk around for a minute, then it goes away. Or so severe, I have to keep moving. I have to stand up. It'll wake me up in the middle of the night, and I got to get up and walk around because it's so uncomfortable. And so these people often complain of poor sleep. And 85% of patients with restless legs have difficulty falling asleep because it usually occurs in the evening and often when our feet are up, more propped up than on the ground. And an equal amount wake up with the symptoms. It can start when you're a kid, or develop when you're an older adult. Symptoms wax and wane, and lots of different reasons. For that, it could just be the natural progress of the disease. It's associated with low central nervous system iron. So as your iron stores kind of shift, that can make symptoms wax and wane. Different things can happen. Medications can sometimes make it worse. So maybe you're on something briefly that makes it worse, and then you get off of it. Sometimes it progresses in more severe cases, but progression is not the norm, like not a given. It doesn't necessarily progress. So Angie asked, is RLS related to the sensation that you're falling? No, that is your body relaxing, and it's a what we call hypnic hallucination. There's lots of different ones. You can see things as you're falling asleep or waking up, or you can hear things as you're falling asleep or waking up. Sometimes people go, "Oh, I thought I heard somebody call my name," like right as you're kind of drifting off. And the sensation as you're falling is probably we think it's related to the relaxation of your muscles. When you go to sleep, your muscles relax. The sometimes jerk, like falling, and then as people go, I felt like I almost hit the ground or something more. That big jerk is called hypnic myoclonus. It's just the input from your nerves to the muscles goes down when you fall asleep, and then the input comes back real fast, and then your whole body jerks. So it's not related to the sensation of falling. It is an urge to move, usually your legs. It occurs in about 7% of the US population. Has been shown to be associated with an increased risk of stroke, coronary artery disease, and hypertension, probably from disrupted sleep. Work productivity is reduced up to 50% in people with RLS. To get poor sleep, they're uncomfortable. If they're sitting at a desk and they don't move, it might be something where, okay, I got to take frequent breaks and stand up, and so not as much done. And quality of life is also reduced to a similar degree. Really, it's not, it inherently, we don't think it is inherently itself dangerous in terms of directly causing any health problems, but it is extremely uncomfortable for people to have it. They hate it. Things that worsen restless legs. Anemia. So if you have low blood or low iron, most of these people have iron deficiency. You're more likely to have worsened restless leg symptoms. Pregnancy, you may have only had it when you're pregnant. That during pregnancy, you had restless legs. Once you gave birth, it went away. This occurs in 15 to 30% of patients that are pregnant. Also, things that worsen it are caffeine will worsen RLS symptoms, alcohol will worsen RLS symptoms, antihistamines, antidepressants, and diphenhydramine. So Benadryl. Benadryl really, really, really worsens restless legs. And sometimes Benadryl, diphenhydramine is hiding in things. If I got a head cold, I'm going to take the nighttime, cold and flu thing. Well, the nighttime cold and flu thing often has diphenhydramine and Benadryl. So people sometimes go, "Oh yeah, my restless legs got worse around I got a head cold," because they were taking stuff with Benadryl. You diagnose it by history. It's all clinical symptoms, and the treatment, iron supplementation. Now, not everybody is iron deficient. They might have actually normal levels of iron and iron storage in their body, but if it's below a certain level, is associated with having more symptoms. So for most people, iron supplementation is needed. And then medications are kind of the mainstay. The first line are gabapentin and pregabalin. Gabapentin is also called Neurontin, but it's mostly generic now. And pregabalin is also called Lyrica. Those are the first line because they are the most effective and they don't cause something called augmentation. used to be these other drugs, Ropinirole, brand names are Quip and Pramipexole. The brand name is Mirapex. These are dopamine agonists. But we found out many years ago that these medications cause augmentation, which is actually worsening of the RLS symptoms with long-term use. And so the longer you're on them and the higher dose you're on it, the more likely you are to get augmentation. So what happens is kind of a double-edged sword. You take the medication and go, oh, well, it's working for my symptoms. But over time you go, well, when my symptoms are getting more severe, they're happening earlier in the day. First, it was just in my legs. Now I'm feeling the same thing in my arms. And you go, but the natural the logical thing back 10, 15 years ago was, oh, symptoms are getting worse, let's increase the dose of these drugs. So okay, go higher drugs. Okay, now start taking some. You were taking some just in the evening or right before bed. Now start taking some during the day. Oh, that works for a while, but then they start getting worse again because it's causing augmentation. It's worsening the restless legs. It's a vicious cycle. Other things, avoid alcohol, especially close to bedtime, if that's when the symptoms start. Caffeine, other exacerbating substances, medications can be. So sometimes if you're on antidepressants and take them at bedtime, probably better to take that in the morning. Moderate exercise will help. So moderate exercise during the day. More vigorous or strenuous exercise can actually make it worse. Stretching, so stretching your legs before bed, or warm baths, or soaking your feet can help. And then there's some old wives' tales, but people tell me this works. I get patients. There's not a whole lot of like randomized controlled trial data, strong evidence for this, but patients have tried it and it's worked. Mustard, just straight up mustard, a spoonful of mustard. Tart cherry juice. That's going to be tart cherry juice, not just cherry juice, tart cherry juice. And then my favorite one is a bar of soap in their bed. And we've heard different particular bars of soap. Irish Spring, and I've also heard Dove. So you sleep with the bar soap in the bed with you. Again, there's no randomized control trial. It's not strong data for this because nobody's done it. I would love to see it done. Just amusing, but people tell me, hey, heard stories that it worked. Not too much harm with any of these. If it works, it works. Go for it. So thank you very much. And I'll take any questions. Oh, Lauren Ryan, let's see. Lauren Ryan says, my son, 10 years old, says he falls asleep better with the light on. Is this okay? He also bouts of night terrors, so I'm inclined to accommodate the light requests, but worry he won't sleep as well. Your worry is well founded. He will not sleep as well. I think it's okay to have a light on as he falls asleep, but I would turn it off later. Night terrors happen out of deep slow wave sleep. So waking up screaming, horrified, sweating, heart racing, but then have no memory for it. The treatments for that is to make sure it's not, there's no there's something where they can't completely wake up, because what we think of with this, it's called parasomnia, is what happening is incomplete arousal out of that deep sleep. So is there something that is not letting him completely wake up from that? That's usually, probably not in your 10-year-old, for adults, that's, medications, sedating medications. So people that are on Ambien, say, have parasomnias. They don't completely wake up. Sleep-related eating, off topic, is something that happened a lot. People wake up and eat in their sleep, or partially wake up and they eat in their sleep, and they have no memory of it. But the other thing about trying to reduce, the frequency of these events, or these events from happening, is there anything that's arousing them? So remove things that are arousal. So noise, light. So, and there's actually, in teenagers and teens, preteen, they've shown that ambient light is associated with less slow wave sleep or sleep, and actually the development of diabetes in patients, in teenagers, and with that, just the ambient light when they're asleep, so that it's going through their eyelids and they're getting exposed to that. So I think it's okay to if he feels like he needs it to fall asleep, I wouldn't put, kind of like minimal amount of light as you can get away with, but then turning it off after sleep because it may be something that's waking him up. Yeah, and then turn it off when he certainly can be growth spurts. You get growing pains happen at night. That's something that might wake him up. Let's see. Somebody asked room temperature recommendations for insomnia. Cool. So whatever is cool for you, usually, you know, I'd say somewhere around, you know, 70 or lower. You know, get under the covers. You don't want to be cold and wake up freezing, but cool. You want the bedroom to be dark. You want it to be cool. You want it to be quiet. That is the best. We sleep better actually when it's the bedroom's cool. Not.
Someone asked about nocturnal leg cramps.
Yeah. So that's different from less days. So you just, you know, you cramp at night. Make sure you're hydrated. Sometimes that happens with dehydration. There you go. You're fine during the day. Then you lay down at night, you maybe drifting off, and you do a little stretch. You point those toes, and then all of a sudden your toes don't want to come back up. Your calf cramps really bad, you know, and you wake up, you know, squeezing and rubbing it. Make sure you're hydrated. And if it does happen a lot and you're well hydrated, yeah, the mustard tart cherry juice for those work. And some magnesium. Magnesium supplements can help with that.
And then someone was asking about, is there ever a good time to take supplements like melatonin, CBD, etc.?
Not really, because there's not great evidence that these help with insomnia. There are times where melatonin can be useful, but that's when insomnia is not actually insomnia, but it's a circadian rhythm problem. So your body clock tells you when to go to sleep and when to wake up. So sometimes people's perceive things as insomnia. Oh, I have trouble falling asleep. It takes them hours to fall asleep because they're trying to go to bed at 10, but the body clock says no, 1 o'clock is sleep. And left to their own devices, they go, well, what happens when you go to bed at 1? Well, I fall asleep instantly. And then when do you wake up? You know, and left to your own devices, okay, you don't have to get up for work. On the weekend, what do you do? Well, I stay up until 1, I fall asleep easily. And then I wake up around, 10 in the morning. Which doesn't work when you have to go to work. So they go, okay, well, it's work time, so I need to go to bed at 10. Well, it takes me 2-3 hours to fall asleep, and then I got to get up at 6, and they're getting up too early. So then it's helpful because melatonin just tells your brain it's dark outside, so you take it early to try to trick your brain to say it's dark outside and move that bedtime forward. But insomnia, there's no evidence that it helps. CBD, the same thing. Also, with supplements, including melatonin, is that you don't know what you're getting or how much you're getting. So there's a lot of different cannabinoids out there. They have slightly different actions on the receptors and what they do in the brain. And sometimes what happens even with the prescribed medications is people say it's the cognitive part of the insomnia. They say, I can fall asleep now because I've taken something. Not that it's actually doing anything. There was a really nice study 2 years ago now where they divided people up who were on, hypnotic medications into a group that would wean down on the medication, a group that would wean down on a placebo, and a third group that was cut off cold turkey. So the group that was, you said, just stop your hypnotic, reported worsening of their insomnia. There was no difference between the group weaning down on the actual medication and the group weaning down on the placebo. So sometimes I worry about anything when I go, okay, I do this and it makes, helps me sleep. Does it itself help you sleep? Was CBD actually doing anything physiologically for sleep, or is it doing something more psychological where you go, I've taken something and now I can, I've given myself permission to fall asleep. And that's kind of what that study shows, is that it's these things are more of a placebo effect. So then the problem is, are you going to get untoward side effects? And sometimes CBD has been shown in some studies to be worse for your sleep, and that you might not get as deep sleep, or it's more disruptive to sleep. So I don't ever really recommend supplements for insomnia because there's not a great evidence, and also because you don't know what you're getting. You know, even the melatonin, I only recommend, when I do recommend taking it, I only recommend certain brands because there was studies shown that said you don't know what you're getting. You know, there's some, you might take a melatonin pill that has absolutely zero melatonin because it's not regulated the same. It doesn't have to have the amount they say they do in them. So with CBD, you might be getting like mega doses in one thing or nothing at all. You know, how much are you getting? I don't know.
Thank you so much, Nathan. I think that we're done with all of our questions now.
Okay.
Very, very informative, and thank you so much for sharing your time.
My pleasure. Thanks for having me.
Thanks a
All right.
lot.
All right.
Bye-bye.
All right. Take care. Bye.
Bye.